getting that recording right now. Also, want to make sure that you all look at your name in the attendee window. And if you have not indicated the name of your facility next to your name, please do so by right-clicking on your name and editing your name to include the name of your facility. I have unmuted Pam Richmond, Vicki Bartlett, and Steve Wormuth at this time. Do you have any opening or welcoming comments?
Arlene, this is Steve, and welcome everybody. Couple of things real quick. Number one, congratulations to those OASN members who are going to be recognized from the Molina P4P project and everything. So great work on that. And then the other thing is, just as an FYI, Leading Age Ohio did put out another date for the MDS inspection webinar, meeting, training, and everything. So please look for that. I did have our folks put that on the OASN website. So if you're interested in attending on that additional day, please look on the OASN website for the registration for that event. And with that, Arlene, I'm done. Thanks.
Thank you, Steve. And I know the first session filled up, it was March 13th. The second session for that is March 15th. So if you'd like to attend and you didn't get registered, please sign up for March 15th. We are getting some background noise from someone, so if you could please mute your phone. Pam, Vicki, did you have anything that you'd like to say in opening the meeting?
I don't have anything, and I think I'm part of the background noise problem, so I'm going to mute myself.
Okay, thank you, Vicki. And I know Pam was possibly going to stay muted for this meeting also. I did want to give you the names. They are on the agenda of those facilities that Steve mentioned to congratulate the top performers from OASN on the Molina Quality Living Program. They are Otterbein, Lebanon, Bailey, Bethany Village, Friends Care Community, and Greenwood Manor. So great job to everyone. We appreciate that. We're going to start our agenda with a presentation from Deborah Melito from Diamond Pharmacy. Steve, did you want to introduce Deborah while I unmute her?
Sure. Thanks, Arlene. So, folks, Diamond Pharmacy has been working with about 4 or 5 of our OASN members over the past year and helping to control some of their pharmacy costs through some interactions with their some of their programs. Deborah's going to take us through that and show us what they've been able to do as far as making sure that medication management is kept at the highest level, which also then is good for our residents in our facilities, but then also in controlling costs and in presenting that to you. And so if hopefully some folks in the future would be interested in engaging with Diamond Pharmacy for some of that help as well. So Deborah, I'm going to turn it over to you and let you do your presentation. Thanks.
And Deborah, you are unmuted. Deborah, are you there? We don't hear you if you happen to be talking.
Okay, can you hear me now?
Yes, we hear you. We hear you well.
All right, I'll repeat. Thank you, Steve, for that kind introduction, and good afternoon to everyone on the call. I was honored to be asked to do this this presentation this afternoon for all of you. And just to give you a little bit of background, I have 2 different consultant groups that that we work with. I'm the director of all the consultants that we have throughout Pennsylvania and Ohio, and I also go to several facilities myself to consult. So the whole educational piece of our consulting is is really foremost for me. I know that, you know, the cost of the medications and the service that we provide, and also the education, it all goes together into one piece. So I think that's what you're going to see by this analysis that I present today. Again, I'm the director of all the clinical and consultant services for Diamond, and I'm the chief antimicrobial stewardship officer for all of Diamond. And I'm also the chairman of the Antimicrobial and Infection Control Stewardship Committee at the national level of my organization called the American Society of Consultant Pharmacists.
Well, welcome.
Thank you. Next slide. So we're all familiar, I think by now, the CMS mega rule. The first time that we've had a revision in 25 years. And I'm sure all of you have read all 700 pages of the mega rule. But I'm just going to focus on some pharmacy services issues, just making sure that kind of a checklist for all of you on the call today, that your pharmacy, you know, is making sure you're in the loop with all of this. And if you're not, we can always you know, come to your facility to do in-services. You don't have to be a client of Diamond. We'd be more than happy to do that. So the first phase was November 28th of 16. Next slide. And this is where they sort of rearranged the regulations, if you will. So anything with that double S means that it is a regulation and you must do it. Okay, and a lot of people were a little confused about what that meant, but that's really what it means. And then you see there's F tags that are associated with different with the different regulations. So some of the numbering has changed, and maybe the location of some of the titles have changed as well. So going to the next slide. Unnecessary drugs became very important to CMS. And they've always been important to my Diamond consultants, because every month that we do a medication regimen review, we're looking for any unnecessary drug that's in that regimen, which includes excessive dose. So that's if you have duplicate therapy. And we're constantly reviewing that to see if you're on, let's say, for instance, an omeprazole, which is a proton pump inhibitor, and a pantoprazole by mistake, because that's what they were on in the hospital. We're also looking at duplicate antibiotic therapy. So if someone's on a pretty, you know, high-powered antibiotic and they're put on another one that has the same coverage, we would recommend to DC that. For excessive duration, so, you know, there's many medications that don't need to continue forever. Like if you're getting something for an upset stomach or gastric irritation or a wound, once that's, you know, resolved and or healed, you would want those medications to stop. So like with our antimicrobial reporting that we do, we actually do a report every month for our facilities, and we're looking at every single antimicrobial order. That includes topicals, like your nystatin powders, to be used every shift. I don't think those need to continue for 3 and 4 years. So we need those to have cut dates too. Then we're looking at any med that doesn't have adequate monitoring. That could be anything from lab work that needs to be ordered, or perhaps someone's on an antiplatelet or an anticoagulant, and we would make sure there was adequate monitoring for bruising or bleeding. Without adequate indications, how often we see medications with maybe with no diagnoses or with an inappropriate diagnoses. And so we're going to make sure that every medication that resident is receiving has an adequate indication. If not, it should probably be DC'd. And then if there's any adverse consequences to any a dose of medication that's reduced or discontinued. Okay, next slide. So some of the unnecessary medications that we sort of focused on were anxiolytics, antipsychotics, and proton pump inhibitors. And the anxiolytics would fall under the category of the 14-day PRN use, which I will talk about. Antipsychotics, again, 14-day PRN use, but with more stringent controls. And the proton pump inhibitors that we all know are not as innocuous as we once thought. There are a lot of collateral damage to using unnecessary proton pump inhibitors. And what I'm referring to there would be like Prelosec, pantoprazole or Protonix, Nexium. There's a lot of generic names to all of those. But we know that that group of medications can lead to one item in particular, which is Clostridium difficile. And if someone does contract C. diff, there's a lot of money that's spent. There's high cost in treating C. diff because usually it can be treated, well, most of the time it can be treated at the nursing home, but if it's a moderate to severe case, they're probably going to go to the hospital. And so it's anywhere from $2,000 and up in dollars spent on a C. diff case. So we want to prevent that from occurring as much as possible. So we are asking the question on admission, is this a medication that needs to continue? Because oftentimes you're put on that in the hospital, but you really don't need to be on it once you're discharged. So let's, get it off of the profile from the beginning and not let it hang there and can cause fractures, pneumonias, C. diff, and low B12 and magnesium levels. Next slide. So we were looking at our data for the number of chronic medications per resident at the 5 facilities that we have in Ohio. And you see I've named them A, B, C, D, and E. The averages, anything over 9 is considered polypharmacy. So you can see most of them are over 9, but it's something that we are working on a monthly basis to make recommendations for de-escalation of these chronic meds. Now, there are times when you just can't DC any of the meds. Like if someone has congestive heart failure, diabetes, and COPD, that will easily be over 9 meds. So that's justifiable. But we're looking to see if someone is on multiple vitamins, like a multiple vitamin, and then they're on vitamin C and vitamin E and vitamin A. We're asking, does that really need to continue like that? Sometimes we get really good buy-in from the physicians, but sometimes the physicians will say patient request, family request. So it's just something that we look at very closely every month. Next slide. This tells us about the PRN medications that are used per resident. So some are better than others, as you can see. Facility A is doing very well. Anytime a resident hasn't used a PRN medication for 30 to 60 days, we are going to make a recommendation to have that DC'd. Because if they need it again, the nurse can always call the provider and get an order at that time. There's no sense in having, a Robitussin DM, an Imodium, and a Sunna as PRN orders. Once, that has resolved itself, those should be DC'd and off of the medication administration record. So that's something that we are continuing to look at on a monthly basis. Next slide. Now, this was Facility A that they did a really good job on looking at different classes of medications and making actual recommendations to decrease or to DC certain medications. First, you see antidepressants. So antidepressants, kind of a tough class of psychotropic meds to get DC'd or decreased. So what we decided was that any resident that was on 2 or more antidepressants, we were going to tackle that group of residents first and see if we could get at least one of them DC'd if the resident wasn't experiencing any depressant behaviors or anything like that. So that nicely went down from 180 of the first quarter of 17 to 169 in the fourth quarter. Inappropriate dosing of antidepressants, there were a few, not too many, but you know, we were looking at that, and that has a lot to do with like the XL and the XR formulations, you know, those extended release formulations that sometimes they get misconstrued coming from the hospital on XL, and then it's entered into the system as just plain. So that would never last, the effect would never last a whole 24 hours like an XL. And that's part of our medication reconciliation that we do. For every new admission and readmission to your facility, we do a remote consult, and we're looking at med reconciliation to make sure that what they were getting in the hospital is what the nurses entered into the EMR system. And we oftentimes find discrepancies, but as the pharmacists and being the drug experts, I feel that we are best suited, you know, to do a really good med reconciliation. Back to the antipsychotics. So we were making some progress there, and then I think that there was a change of acuity for some residents that were admitted to Facility A, but they're still well below the state and national averages. Anti-anxiety. No surprises here that this has gone down from 44 to 36. And I'm going to talk about that in a minute with the new CMS regulations with 14 days. And then proton pump inhibitors, a dramatic response from 141 to 81. That was excellent that that occurred. Next slide. Okay, these were the other facilities, B, C, D, and E, and there were PPI recommendations made, antidepressant recommendations made, and some general, like gradual dose reductions, which would be under psych. So again, I meet with my consultants every 2 months. I actually come to Ohio and I meet with them, and I have, you know, reviewed all of this data with them, and I think we'll see more of an improvement since we now have more data for these 4 facilities. We didn't have as much data as we did for Facility A. Next slide. Okay, continuing then to CMS Mega Rule Phase 2, which went into effect November 28th of 17. Next slide. And that has to do with infection prevention and control, which also under that umbrella is a effective antimicrobial stewardship program and a robust immunization program. Next slide. So what are we doing in regards to that? Well, this is something that is dear to my heart. I probably speak on antibiotic stewardship, infection prevention, and control almost on a daily basis at our regional level, but also in the state level and the national level. And I go over different topics with the consultants every 8 weeks so that they can speak to it as well. And we send monthly antibiotic stewardship notes to every one of our facilities about a timely topic so that they can add that to their antibiotic stewardship binder and educate their nurses about items like that. So we are doing a review of the antimicrobials that are used at your facility on a weekly basis from a remote standpoint. And then when we're there, we're looking at every chart concurrently to see if there's, you know, a cut date that's needed, if there's an appropriate diagnosis that's needed. And we follow the CDC core elements for an effective antibiotic stewardship program, and those are the guidelines that we use to make sure that your facility has all the components that they need for an effective antibiotic stewardship program. Again, we can come and do in-services for you, show you those checklists, show you the core elements, and make sure that you're at least doing, you know, reporting on one outcome and at least one process. at your QAPI meetings. And we attend your quarterly QAPI meetings, and we can do different performance improvement projects or PIPs with you to make sure that, you know, maybe there's something in your antibiotic stewardship program that you need some help with. Next slide. Other items that we're doing for antibiotic stewardship is, you know, again, I mentioned about restricting broad spectrum toxic or expensive antimicrobials. We are always looking to streamline therapy or de-escalate the therapy. So if someone is on, let's say, for instance, an azithromycin IV from the hospital, and they come to your facility and they no longer have a fever, assuming they were getting it for pneumonia, their white blood cells have normalized, their respiration rates are okay, we're going to make a recommendation to switch that to PO, because it's just as effective PO as it is IV. Shortest possible duration. We go over disease state management at our facilities all the time. Urinary tract infections at the top of the list. And for most uncomplicated UTIs, you only need 3 to 5 days of therapy. So these days of 7 days, 10 days, 14-day duration on orders, I'm happy to say are starting to go away, but you still have some providers that are hanging on to, you know, the old ages, the dark ages, so we have to educate them. Appropriate indication, so we're looking to see, you know, in that antimicrobial report, are you getting antibiotics for cough and cold and congestion? Those are symptoms. Are you getting it for increased WBCs? That's a lab. Are you getting it for E. coli? That's an organism. So we're making sure that you have an appropriate diagnosis: pneumonia, urinary tract infection, cellulitis, otitis media. Decreasing inappropriate urine cultures. If you were to look in your facilities and see how many urine cultures you're getting that are unnecessary and how much money you could save if you didn't have so many inappropriate ones, that would be a cost savings if you just looked at it from a lab standpoint. But we recommend, based on evidence-based guidelines like the Loeb and McGeer criteria that you have for a lot of different disease states, and if it's asymptomatic bacteria, we shouldn't be getting a urinalysis or a culture or even starting the antibiotic. I talked about collateral damage a little bit, about trying to prevent it. So we try to prevent it by decreasing the proton pump inhibitors, decreasing the duration of the antibiotics, because the longer someone's on an antibiotic, the greater chance they have of developing an adverse effect, such as C. diff. In a robust immunization program, I actually have representatives from Pfizer that talks about pneumococcal disease, and another representative from GlaxoSmithKline that comes in and talks about herpes zoster and the new Shingrix vaccine. So again, that prevents disease from occurring, especially invasive pneumococcal disease, and why it's so important to get both the Prevnar 13 and the Pneumovax 23. Next slide. So this is a rough guide for you to look at. The numbers might not be the same for everyone, but it will give you a pretty good idea. So looking again at Facility A, decreasing the anti-anxiety medications, which would be like Ativan and Xanax. You can see in the first quarter it was approximately $937, and we got that down to $281 by the fourth quarter. Antidepressants went from about $7,000 to about $1,600. Antipsychotics, $1,700, went up a little bit to the $1,900, but again, as I mentioned before about the acuity of the residents that were admitted. And then proton pump inhibitors, very good, with almost 5,000 going down to 1,000. So this is all possible from a very good consulting group that we have that you know, pays a lot of attention to this, and not only for these medications, but these are the ones that seem to, you know, have the most bold decreases. Next slide. Again, with CMS Mega Rule Phase 2, these two parameters or regulations went into effect. So for antipsychotics, PRNs only, can only write them for 14 days. Then they have to be reviewed by the provider in person, and then a clinical rationale written as to why it should continue. So some people have said, oh, wow, this is going to be really hard to do, or why do we have to do this? But if you think about it, if it were your loved one, would you want them to be on an antipsychotic like Zyprexa or Seroquel? Because one time they acted out, and maybe it had nothing to do with a disease state. Maybe they were just uncomfortable, or they were coming down with the flu, or they didn't sleep well. So I think it's good that this rule, this regulation has been put into place, because it makes the nurses do a really good assessment of that resident before they call the provider, and for that provider to give a PRN's antipsychotic order. Next slide. No, this is a little bit different. It's a little confusing, but I'll explain it. PRN psychotropics, on the other hand, are medications like anxiolytics, like Ativan, Xanax, like anything that helps you to sleep, which is a hypnotic, like Trazodone, Temazepam, Valium. Any medications like that, they can only be written PRN use only, not scheduled, PRN, for 14 days. Then the nurse can do the assessment and call the provider and say, oh, I think they need it. The provider can say, okay, go ahead and continue that for 30 days, or go ahead and continue that for 60 days. What I've been seeing, and why I think the numbers have gone down for the anxiolytics, and they've done so in my facilities as well, is because we're getting these DC'd. The physicians have decided, well, I guess if they don't really use it, then why does it need to be there? Exactly. That's what we wanted to happen. That's what CMS wanted to happen. So we're getting a lot of them DC'd, so they're completely off the MAR, and they're bringing down those percentages very nicely. So I do want to make one other comment on that slide, and that's this. This includes hospice residents. Again, a hospice regulations, they have to be reviewed every 15 days, everything about that hospice resident, not just the meds. So it makes sense that these PRNs come off of the MAR if the resident is not using them. And why is that? Well, because CMS, in this mega rule, the premise of all of this revamping was that it had to now be person-centered care. So the days of these hospice kits where every single hospice person received the same orders are over. And we're finding the most pushback from hospice nurses only because they don't know about this. So we're doing a lot of education of our hospice nurses so that, you know, even if they're writing Haldol for nausea and vomiting, same thing has to occur, 14 days if it's PRN, right? If they're writing for Compazine, that is a first-generation antipsychotic. I know we forget about that quite a bit. Again, if it's PRN, 14 days. And then after 14 days, there's this reassessment, and they say, well, they haven't used it. Well, then let's DC that. We can always write for it again in the future. It's not like we can't do that again. We can. And next slide. And then the CMS Mega Rule Phase 3 goes into effect November 28th of 19. And I'm just for the purpose of being complete, I'm just mentioning that the infection preventionist needs to be in place by then. And they have to be educated, trained, and certified. We're not sure what CMS really means by that as far as how many credits or anything like that. But I recommend that anytime you listen to a webinar from the CDC or CMS, or you have a presentation by someone, I would be documenting that because it might count towards whatever qualifications they're going to want for the infection preventionist. And then QAPI, you know, that's going to take on a more important role in all of the facilities in that they will be having monthly QAPI meetings and expecting every department to have some sort of PIP project that they're working on. So in summary, I hope that I was able to show you the different aspects of the phases of the CMS mega rule and how pharmacy services fits into that, and what we're actually doing from a de-escalation standpoint that not only is improving the quality of life for your residents by not having to take not having such a pill burden, but decreasing nursing time and therefore decreasing costs. Thank you very much.
Thank you, Deborah. We really appreciate it. There are a few questions in the chat window that I'd like to read to you. And if anyone else has any other questions for Deborah, if you could please type them into the chat window. The first one is, what is considered adequate monitoring for those on anticoagulants?
Hello?
Can you hear me, Deborah?
Yes, I can.
Did you hear the question?
I did not.
Okay. The first question in the chat window for you is, what is considered adequate monitoring for those on anticoagulants?
Okay, that's a good question. So anticoagulant to me would be something like warfarin or Coumadin. And that's where you would want to have an INR ordered on a regular basis. Now for Diamond, we actually send a memo to our facilities Monday through Friday, letting them know that your residents on warfarin and this medication, usually an antimicrobial, has been started. And we recommend a more frequent INR because a lot of antibiotics can increase the INR. So we would want you to catch that sooner rather than later to prevent an adverse effect. So that's an anticoagulant. An antiplatelet would be like aspirin and or Plavix. And that's where you'd be watching for signs and symptoms of bruising and bleeding. So that would be part of your care plan. The direct orally acting anticoagulants, they're called the DOACs. And that is Pradaxa, Xarelto, and Aliquis. And those are all cleared renally. So we always make sure that we're looking at the renal function of the resident, making sure they're on the correct dose.
Thank you. And the only other question for you is, can they get a copy of this PowerPoint? Now, obviously I have it. Is it okay if I share it with the members?
Absolutely.
Okay, great. Well, we really appreciate your presentation today. It was excellent. If any other questions do come up, I will have them email me and I will get them to you. Steve, any closing remarks for Deborah?
No, Deborah, thanks for your time. It's been great working with you, and I look forward to working with you and the rest of the team from Diamond in the future. Thanks.
Thanks, Steve.
Thank you very much.
I'm going to exit from the call then, okay?
Okay, thank you.
Thanks,
Okay.
Deborah.
Bye-bye.
Bye-bye.
Okay. Are you currently seeing the benchmarks up on the screen?
No.
You still seeing Deborah's presentation?
Yes.
No, all I have is a thank you on my screen.
Okay, hold on. I've got to switch. I have so many things here to pull up. Okay, how about now?
Now.
Okay, we're going to briefly talk about the benchmarks. I know that a lot of you have been asking and are waiting for our 2018 benchmarks to come up. We have been working on this very diligently over the past few months, the quality chairs and strategic healthcare. And what we have come up with so far is we have finalized the benchmarks if we go from the bottom up. We have finalized the benchmarks for Nursing Home Compare. Those are in the golden. We are using the same methodology for that for 2018 as we used for 2017 and 16, and that is the medians from Nursing Home Compare. We've also finalized the CASPER measures for 2018, also using the same methodology that we've used the last 2 years, and that is looking at the national score and the state score and setting our benchmark at whichever is more challenging to meet. So we have accomplished that. Now when I move up to the top, you'll see some green and pink. Those are the quality measures that are taken from the National Nursing Home Campaign National Nursing Home Campaign Quality Improvement Campaign Hospitalization Tracking Tool. That's always a mouthful. And we have been able to work with the campaign, and we've been able to get the state and national medians on some of the measures. The first pink one is the 30-day hospitalization skilled. And you will see that last year we set that at 10.8. We are going to be setting that at 11.1 this year. Then if you drop down to the next pink, that is the 90-day readmission skilled. And then the next two pink are the hospitalization rates. There are 6 measures currently, and these are highlighted in green. This is 30-day hospitalization long-term care, 90-day hospitalization long-term care. These two are observation rate, skilled in long-term care, and ER visits skilled in long-term care. Those measures, there was not enough data currently in the National Nursing Home Campaign to give us a good benchmark to use for 2018. So we have tried a variety of things to arrive at what we think is a good recommendation for OASN for 2018 for these benchmarks. None of them have satisfied us on this committee that is working on this. We are currently gathering information that is taking us a while to gather. It may take us at least to the end of the week to gather to try a new methodology to come up with the benchmark recommendations for this for 2018 for these 6 remaining measures. So as soon as we have those, we will get those to you. Now remember, these are the benchmarks that we are going to be striving for in 2018. We like to have those decided with board approval by April 1st. So we're still within our window of our policy and our goals, and we have been working very hard on that for the last couple months. So we hope to get that finalized soon. Once we get it finalized, it will come to you to make sure you approve. Then it will go to the board for final approval. Once we receive final approval on that, I will give those to Paul at CPMT, and he will load those new benchmarks into CPMT so that we can see on all our reports how we're doing performance related to benchmark. So at this point, Vicki, Pam, Steve, do you have any comments on any of this? And are there any questions from the members on where we are with the benchmarks for 2018?
I'm good, Arlene. You did a nice job at explaining everything.
Thank you.
Yeah, I'm good too. I just for the, for the rest of the folks in the call to know that, we spent a lot of time going through these and made Arlene and Pam especially really work at getting these fine-tuned. So, at the end of the day, we felt we had good benchmarks to put forward in today's call.
Thank you, Vicki. Appreciate that. So we're going to move on. If there's any questions, please type them in the chat window because we have so many on the call, the phone lines are muted. We're going to move on to the Discern Health Achievement Report for third quarter. Hopefully I can get that to get up on the screen and get my other things off the screen. Sometimes when there's this many things, the right thing doesn't want to get on the screen. Hold on one second. Are you seeing in the achievement report?
Yes.
Oh, good. Wonderful. Now, all of you did receive this already, but we always go over this as a committee to see if there are any questions. Where you see these benchmark achievements, this is where we will be putting the new benchmarks for 2018. These are the third quarter results. The fourth quarter ends tomorrow, and I just want to really encourage some of you. You do have some of you have nulls still in the data. Some of you have unapproved data. I had 8 facilities as of this morning who had not entered their data for December of 2017. Just want to encourage you that the quarter is closing at the end of the day and the year is closing. So we really need you to get in there and fill those out. So here are our achievement benchmarks for third quarter. This is the same report we have been using the last few years, so it should be familiar to all of you. Once again, we use the gold flag to indicate whether we achieve that benchmark. And if we look at the benchmarks, you will see here on the right that we achieved 8 of the benchmarks out of 9 for the skilled measured, and we achieved 5 of the benchmarks out of 9 for the long-term care measures. Now, it's really important that all of you know what your individual data is, and you all did receive individual reports because all of our data goes to create the summary report, which we know is used for negotiating of contracts, working with payers, pay for performance contracts, and so on and so forth. So we really want to encourage you to pay special attention to not only the composite report, but your individual report and put in quality improvement. The one area in the skilled that we did not meet for the third quarter is the 30-day unplanned readmissions. You'll see we had that set at 10.8, and our overall performance was 11.2. So we're very close to that, but we did not meet that. If you look at the rest of the measures, and in respect of time, I won't go through every one of them since I know you're all familiar with them, but we are doing an excellent job in meeting all of the measures, the rest of the measures on skilled. I do want to tell you that in looking at these reports, as Vicki had said, we spent a lot of time analyzing 2017 data and sources and what we have learned, and we can really thank the whole committee for that. We have learned that not only are the nonprofits improving their scores, but the for-profits are improving their scores and becoming a lot more competitive to us in the nonprofit industry. So what you are going to see on the benchmarks for 2018 is you're going to see they're even harder to meet than what we met for 2017. Because we can't say that we are doing the best if we set our benchmarks below what the other nonprofits and for-profits are doing. If you look at the long-term care measures here, you will see we're going to focus on the measures that we continue to struggle with. And the first one here is falls with major injury. Benchmark for that was 3.40. We're at 4.45. Now, one of the things that was discussed last meeting was, are we correctly coding the MDS? And are we looking at the definition of what a fall with major injury is before we code on the MDS? We've had one. So that's why we are hoping a lot of you will attend the MDS session at Leading Age. And also, I will be attending that and taking your feedback as to whether we need to have additional training instruction to help us with the coding of the MDS. We may not actually be at 4.45, but we are coding that we are at 4.45. The next one is urinary tract infections. Our benchmark was 3.60, and we were all the way at 5.32. So you can see, once again, whether that's coding or we're actually there, we have a lot of work to do related to urinary tract infections. The next one is flu and pneumonia vaccines. And remember, these are our long-term care measures. Benchmark 97.17, we're at 96.70. We are close, but that can also be coding because remember, we're required to offer the vaccine, and it's important how we code that in on the MDS. And the last one is our pneumonia vaccine long-term care. We're at 98. Our benchmark is 98.22, and we are below that at 97.60. So with that being said, are there any questions on this chart today or any comments? Any comments from Pam, Vicki, or Steve?
Yeah, Arlene, this is Steve. I just think it's important, at least from my perspective, to alert the committee that on falls with major injury, this has been a measure that we have not hit since we have started the quality program. So it is definitely something that I think we need to focus in on. I'm hoping to what Arlene and Pam and Vicki and I have talked about, that if people participate in the MDS exception training, that might have some impact on that number. And then don't forget that we've done a couple of other educational opportunities about different best practices that could be employed as well. So that was one that really has kind of struck out in my mind, that we've just never really hit that mark. So whether if it's a coding error or it's a best practice error, we probably need to really kind of spend some time on that, because not to belabor the point, but a fall with a major injury could lead to a readmission. And so in my mind, it's a twofer. You know, you end up with not hitting one, and then that leads to another one if they end up back in the hospital. If the older adult ends up back in the hospital through the ED, if they go to the ED and are released from the ED, some work that we've done in Southwest Ohio shows that that's about $2,200 to $2,500. If that older adult gets admitted to the hospital as a result of that ED visit, that can be as high as $25,000. So our ability to control this is of value not only to our residents and everything, but also with our value-based reimbursement programs that we're working on with the payers. So thanks, Arlene.
Thank you, Steve. Any other questions or comments before we move on? Okay, I'm going to try to switch to the data automation update. Are you seeing the data automation update?
Yes.
Ah, great. This is an update from Paul Rangsdorf at CPMT, and I just want to go over it with you briefly. One of the things I want to point out, I'm going to scroll down here with the update as of today. All OASN facilities received an email from Voro Health to schedule a day and time for the installation of the BG Connect. This will enable us to pull the information for the CASPR data directly from your MDS. This email came from Rhonda Dowdy, and this is her email. Now, 77 emails were sent to 77 facilities. We only have 15 signed business agreements. So either they went into your spam file or something happened. So this week, 77 more emails went out. As of today, we only have 15 signed business agreements that enable Paul to pull this data from MDS. 7 of the facilities had their installation complete, and it is now working. 6 facilities have installs scheduled. So installed facilities, he wanted me to remind you to continue dropping your files into the BG Connect folder on a regular basis. Is everyone still hearing me?
Arlene, I can hear you. This is Pam Richmond. I'm sorry if there's background noise. Who are the emails going to? I haven't seen this email, or if I did, I deleted it because I had no idea it was coming from outside of OASN. Can someone from OASN forward that to people?
I will ask Paul that question, Pam. That's a very, very good question. We gave Paul the contact list to send the emails to. So he did have the most up-to-date contact list that we had at Strategic Healthcare. But I will see if he can give it to me, because you're all used to getting an email from me, and maybe I can send that out, because I do think that's part of the problem, is people aren't recognizing the email or knowing its importance to open, or it's going in the spam folder, or it's getting blocked.
Yeah, at Ottermine, we're told to delete people's email if we don't know who the sender is.
Okay, great. And it says, does this apply to those who were in the pilot? I believe it applies to everyone, whether you were in the pilot or not. Everyone is going on data automation.
Yeah, Arlene, it's Vicki. We did. I know that the one for my two facilities came to me and to Nancy, who's on this committee, and then we forwarded it to our MDS nurses, and I believe one of them has scheduled. I don't know about the second one.
Okay, great. And then I'm going to scroll up here a little bit because you are going to begin to notice a change in CPMT when you're entering data. And I want to point this out to you because I know as soon as this change occurs this week that I'm going to get a lot of questions. And so I thought I would try to cut the questions off the best I could and be preventative. Here's what you currently see, what I just highlighted in blue here for a second. This is what, well, I'm now moving it, but you currently see UTIs and then this box here to enter for your Casper. Soon, by the end of this week, starting in January, you are going to see a box that now looks like this. Those of you who are set up automatically and you're already done, those 7 individuals, those boxes will be gray down here. And this is what's going to appear in the boxes, a numerator and a denominator. But those of you who are 70 other facilities, you're going to see the boxes that look like this that are not gray. There'll be 100 in the box, and you put your number from your Casper here. So I just really wanted to draw this to your attention because I know if you're anything like me, when I've been doing things for a while and all of a sudden something is different, I'm going to notice that and wonder what's going on and what did I miss or what am I supposed to be doing. Are there any questions or comments on any of this? We're very excited about this phase 1 of data automation. I will follow up on the email and try to be able to send you that email myself. I'm just making myself a note right now. And please, when you go back to your facilities, if you could look for this from Voro Health, because the email is going to have information in it that must be signed and returned due to the due to HIPAA compliance before anything can move forward for your facility. Any other questions or comments on that? Okay, the last thing I'm going to try to pull up. Are you seeing the Molina contract?
Yes.
Yay. Okay. I didn't know if there were any questions. This went out to all of you. I also apologize. I didn't know I was supposed to redact this so that you didn't see the detail on all of the individual facilities, which I'm going to scroll over and get those off right now. So in the future, when you get this, those will be removed. But I wanted to make sure that all of you understood this program with Molina, and that you understood why you may or may not have received reimbursement. So there are multiple criteria for this contract. And if you need that criteria, again, please contact me and I'll be happy to send it out. But the first thing that happens for this contract is the facilities are rated excellent, good, fair, needs improvement, or they could be rated that they're too new to rate. In order to qualify for the pay for performance dollars, you must receive a rating of excellent or good. Then we move on to the next column. And this is your Molina dual options, residents, opting in, and your member count. In order to receive payment on pay for performance, you must have at least 5 duals in your facility. So if you see these numbers here, you see how this person had 4, so that's highlighted they didn't qualify, but there's a 5 it qualified and so on and so forth. You need to have 5 or more. So you could have not got the pay for performance dollars because you didn't have excellent or good, or you didn't have 5 or more facilities. The next criteria for that is the must meet Okay, no, the next criteria, I'm sorry, going forward, I'm trying to read the chat window and messages as they pop up all at the same time. So there's 3 value added measures here. And if you see, they have given us the Ohio average and the national average. And they have highlighted in green the average that is the most difficult to meet. So in order to qualify for the dollars, you must have met those. And see, they've done a really nice job of highlighting for us who met those and who did not. And if I scroll down, you'll see this goes all the way down. So if you are taking Molina, you can find yourself on this list and you can know exactly why you did not get these dollars. The first one, percent of long stay residents with a urinary tract infection, you'll see we have a 2.51 who met that mark, but we also have someone with an 11.67. If you remember back to what I just showed you on the Q3 report, that is a metric we are not meeting as a composite. The next one is percent of long stay residents with a catheter inserted and left in the bladder. We need it to be 1.70. You'll see that down here. But I'm surprised 1.96 is on here in blue. I need to check with that to see if that they were going by the 2.17. I didn't see that before. And then the third one is percent of high risk long stay residents with pressure ulcers. Once again, you'll see the blue met that, the pink did not, and that will go all the way down. So you can scroll to the left and you can find your facility and you can read along, see what your rating is, you can see how many you had, and you can see how you scored on those measures. Now there's also 2 measures that the facilities must pass, both of them, to receive the pay for performance dollars. The first one is percent of long stay residents who were physically restrained, and the next one is percent of long stay residents experiencing 1 or more falls with major injury. And what did we just talk about is that that is a measure that as a composite we have not met since we started the network. So if you scroll down, you will see who met that mark and who did not. Once again, highlighted by pink did not and the blue did. So this column tells you whether these facilities met these metrics and these facilities didn't meet them. And finally, it tells us who received value added dollars at $10 per resident for 3 months and who did not. You will see that we did have facilities who did receive that. And they gave us a really nice column here, I believe, in this report, because it tells us who would have received money had they met their quality measures. So if you scroll down, you may see your name next to one of many of these in white who would have received dollars if they had met those measures. And moving to the last column, well, the last 2 columns, facilities were rated with a level status. And as you know, we are congratulating those platinum, gold, or silver members who had this outstanding performance on this contract. And we did acknowledge them. We sent that out to you. It is on the agenda, and we talked about that today. Those facilities, in addition, will receive a plaque. They will receive a special gift for members. And I know what else they received, but it's leaving me as I'm trying to rush this at the end. But one of the things that they received also was Resident Life Enrichment Supplies Assistance dollars. And you will see that they received those dollars to purchase those supplies for the residents. Now, you did receive the same report for 2 quarters. We will receive this on a quarterly basis, and it will be shared with you. And we just wanted to make sure you understood the report and to see if you had any questions today for any of us. So any questions or comments, please type them in the chat window. Pam, Vicki, Steve, anything you would like to say?
No, thanks, Arlene. Nice job to everybody, and Arlene, you did a great job explaining everything.
Thank you.
Ditto from me.
Thank you. couple comments. I can, one person is saying the 100 does that correlate to the number of residents. Our census is only 44. Let me scroll back to where she could be asking that question. I apologize, I'm not quite sure where, which column you are asking that question from, but could you email me?
Arlene, it's not from this report. It's from when you were showing the CPMT entry screens. There was a box over 100, and as I was reading it, said something about don't change the 100, which it just may be that the 100 is there for however they programmed the methodology in CPMT to capture the data and give you the right percentage.
Yes, and here's what it says. It says there will now be a second text box pre-populated with 100. Enter your data in the first text box until automation is in place in your facility. Leave 100 in the second box. If the second box is empty, please leave 100. 100 will be populated and needs to remain in this component for the calculation. Does that make sense? I hope. And then if the next question is, if we did not see this email, who do we contact? Please contact me and just be specific. We went over so much information today in this agenda that I may not know which email it is that you didn't see. So if you could just be specific, I will get you what you need. And in respect for time, it is 3 minutes after 3. We like to keep these meetings to an hour. Any closing remarks from anyone or any questions? We really appreciate your attentiveness. We appreciate the attendance today. We appreciate the hard work everyone is doing. Any closing remarks from anybody? Pam, Vicki, Steve?
Nope. Thanks, Arlene. Thanks, everybody, for your time today.
Okay, thanks so much. Look forward to talking to you. Please get that quality data in. Tomorrow's March 1st. Thank you so much. Have a good day. Bye-bye.